We are going to case present in pediatrics. Coming to demographic details. A 5-year-old female child named XYZ from Chittipeta admitted on 12/7/2026. The history was provided by her mother, named ABC, a 35-year-old staff nurse by occupation, and the information obtained was reliable. Chief complaints: fever since 2 days back, rostered for 1 day, cough since 2 days, throat pain since 2 days back, rostered for 1 day. History of presenting illness: the child was apparently stable until 3 days before admission at following. The patient presented with fever of 2 days duration, acute in onset, high grade, non-progressive, associated with 2 episodes of chills and rigors. Fever had an interfebrile period which is active and showed no diurnal variation, relieved upon taking medication. Wet cough 2 days back, which is acute in onset, progressive in nature, which is also intermittent and aggravated during morning, not associated with chest pain, and post-recessive vomiting but associated with breathings. She also developed throat pain, which is acute in onset, non-progressive, associated with wet cough. No history of headache, no history of vomiting, no history of burning imputation, no history of abdominal pain, no history of regurgitation, no history of loose stools, no history of seizures, no history of skin rashes, no history of ear pains are observed. Past history: child is a known case of spinal muscular atrophy type 2. She was diagnosed at 13 months of age following evaluation for delayed motor milestones. She has been regular follow-up with pediatric neurology team since diagnosis. The disease has mainly affected her gross motor functions, while cognitive abilities are preserved. There is no history of suggestive of development regression. Treatment and hospital course: the child received Zolgensma gene therapy during her 2nd year of life. She has been undergoing regular physiotherapy and rehabilitation since diagnosis to maintain muscle strength and joint mobility. She had a recurrent respiratory tract infection requiring multiple hospital admissions. Last year, she required ICU admission with ventilator support due to severe respiratory illness. She continued to attend regular follow-up visits and receive supportive multidisciplinary care. There is no history of tuberculosis, bronchial asthma, epilepsy, or congenital heart disease. There is no history of previous surgeries or blood transfusions. There is no known history of drug allergy. Immunization has completed as per national immunization schedule. She is receiving nutrition support and regular monitoring during follow-up visits. Antenatal history: parity index G2, P2, A0, L3. L3, why I mentioned L3? Because it is a twin pregnancy. Diagnosed with thyroid during her 2nd pregnancy. During her gestation period, she went through all ANC checkups and also took iron folic acid along with calcium supplements. All antenatal scans are done, which is normal. Vaccination was done, that is to TT 2 doses. No history of torch infections. Birth history: 2 babies were born at 34 weeks of gestation by lower segment cesarean section, which is dichronic diamniotic babies at Tanuko Hospital. She was born preterm with a birth weight of 2 kgs and cried immediately after birth, indicating good immediate adaptation. There was no history of birth asphyxia, need for neonatal resuscitation, or NICU admission. The baby was initiated on breastfeeding successfully. The other child is boy child. That too, he born with a weight of 2.5 kgs. Postnatal history: the child cried immediately after birth. There was no history of birth asphyxia, neonatal jaundice, seizures, sepsis, or NICU admission. She was breastfed adequately and passed urine and meconium within the first 24 hours. The child remained well during neonatal period. However, delayed motor milestones were noticed in infancy. She was subsequently diagnosed with spinal muscular atrophy type 2. She received a single dose of Zolgensma gene therapy at 3 years of age. Family history: born to non-consanguineous marriage, no family history of hereditary disorder. Father is a known case of diabetes mellitus and thyroid disease. Maternal age of conception was 29 years. This is a pedigree chart. uh, following first grandmother and grandfather, both the families, mother family and father's family. Development history. Gross motor milestone delayed. Unable to sit without support. Able to sit with support for a short duration. Unable to stand with support, with or without support. Unable to walk. Fine motor milestone age appropriate. Able to grasp and manipulate objects appropriately for age. Language or speech. Speech delay present. Able to understand simple comments. Expressive speech delayed. Social and adaptive. Social and adaptive milestones are age appropriate, good eye contact, interacts appropriately with parents and surroundings. Development history. Child has isolated gross motor development delay. She is unable to sit without support, can sit with support only for a short duration, and is unable to stand or walk. Fine motors and the social adaptive milestones are age appropriate. Language milestones were mildly delayed initially. Here, monosyllables should be appeared at 6 months, but in her case, monosyllables have appeared 9 months. Frequently, bisyllables also late. It should be appeared in 8 months, but bisyllables have appeared at 12 months. Here, meaningful words are appeared at correct time, with subsequent language development appropriately for age. Not a global development delay. Cause why I mentioned is not a global delay, because gross motor delay is observed. Other fine motor and language and social adaptive are normal. Diet and nutrition issue. The child was breastfed within 30 minutes of birth, and first feed was colostrum. Breastfeeding was initiated within 30 minutes and continued for an appropriate duration. Exclusive breastfeeding was given along with top feeds, formula milk. Complementary feeding was started at 7 months of age, beginning with rice and rasam. The amount and frequency as complementary feeds were appropriate for age. This is when the child is born. The table describes the nutrition history before she admission. Here I thought that calorie intake is much calorie deficient is present and protein deficient present, because she was not much eatable. Immunization history. The child is fully immunized for age according to national immunization schedule. In addition, she used to receive the seasonal influenza vaccine annually in 2024 and 2025. The next annual dose is due in August as per seasonal influenza vaccine schedule. Socio-economic status and environment. The family consists of 5 members, including the father, mother, and 3 children. The father is graduate and owns a small shop, while the mother is graduate, nurse working as a staff nurse in a PHC. The total monthly family income is approximately 60,000. According to modified Kupuswamy socio-economic scale, latest classification, the family belongs to upper middle socio-economic class. Environment. The child belongs to nuclear family of 5 members living in a well-ventilated Pakka house with adequate lighting, safe drinking water, sanitary latrines, proper drainage and waste disposal, and a clean, hygienic environment. Summary of the history. This is a 5-year-old female child born of a non-consequential marriage who is a known case of spinal muscular atrophy type 2. Diagnosed at 13 months of age after evaluation for delayed gross motor milestone. She presented with fever, cough, and throat pain of short duration. She has significantly gross motor delay with inability to sit independently, stand, or walk, while fine motor and social adaptive milestones are appropriate for age. She received Zolgensma gene therapy during her 3rd year of life and has been regularly physiotherapy and pediatric neurology follow-up. She has a history of recurrent respiratory tract infection, including 1 ICU admission requiring ventilator support. Birth and antenatal and immunization history are unremarkable. There is no significant family history, and she belongs to a middle socio-economic family living in a healthy home environment with good parental support. Overall, This is a case of genetically conformed SMA type 2 with a predominant gross motor impairment and recurrent respiratory complication. Currently managed with disease-modifying therapy, rehabilitation, and multidisciplinary follow-up. Coming to anthropometry. Weight 11 kgs, height 92 centimeters, BMI height 14.2 kg per meter square, head circumference 49 centimeters, chest circumference 49 centimeters, mid-arm circumference 13 centimeters, skin fold thickness 11 millimeters. Weight and height are less than 3 percentile, whereas head circumference and chest circumference, mid-arm circumference, they are less than 50 percentile. Here in this case, the child is small for age gestation. Skin fold thickness is generally measured by caliper instrument. General physical examination. Child is conscious, alert, playful, cooperative during examination. She appears poorly built and poorly nourished. She is socially interactive and respond appropriately for her age. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema are all absent. Vitals. Pulse rate was 133 beats per minute, regular in rhythm, normal in volume, character with all peripheral pulses palpable equally. There was no radial delay or radiofemoral delay. Blood pressure. Blood pressure was 100 per 70 mmHg with no significant difference between upper and lower limb blood pressure. Respiratory rate. Respiratory rate was 40 breaths per minute. Paradoxical breathing was present. Temperature was 97.7 degree Fahrenheit, that is 36.5 degrees Celsius. The child was febrile at the time of examination. Oxygen saturation was 97% on room air. She was in Bronx. NASA Bronx have been given to the child, indicating adequate oxygenation with no evidence of hypoxemia at the time of examination. Head to toe examination. Head to toe. Head is normocephalic with no craniofacial abnormality. Skull was normocephalic with no cranial deformities. Hair is normal distributed with normal texture and no scar lesions. Face is symmetrically with no facial dysmorphism. Eyes are normal. Conjunctiva is normal. No icterus. Sclera is no icterus. Pupils are equal reactive to light. Pinna are normally placed. No ear discharge. Hearing appear normal. No nasal discharge. Central place in tongue. Mild fasciculation are observed in this case. Oral cavity. Oral mucosa is moist. Tongue centrally placed with no oral ulcers or cleft palate. Dentition is appropriate for age. Neck with no lymphadenopathy has less neck control. Chest is bilaterally symmetrical with reduced respiratory movements. No chest wall deformity. Partial breathing chest depressions. Spine showed thoracolumbar scoliosis with kyphosis. Upper limb, no deformity. Muscle bulk is reduced with hypotonia. Lower limb, no deformity. Generalized reduction in muscle bulk with hypotonia. Unable to stand or walk independently. Skin is normal with no rashes, pigmentation, edema, or urocutaneous markers. Coming to systemic examination. Central nervous system examination. First, primary mental higher mental functions. The child is conscious, alert, cooperative, playful. Higher mental functions are appropriate for age with normal attention, memory, orientation, speech, intelligence, and behavior. Signs of meningeal irritation. There are no signs of meningeal irritation. Neck rigidity, Kenigstein, Brudzinski sign are absent. Cranial nerve. We elicited all the cranial nerves, first cranial to 12 cranials. We observed that there are no abnormalities are seen. All are normal. All 12 cranial nerves are intact. Pupils are bilateral equally and reactive to light. Extraocular movements are fully in all directions. Facial sensation movements are normal. Hearing is normal. Palatal movements are symmetrical. Gag reflex is present. Tongue is centrally with mild fasciculations and shoulder shrug is normal. Motor system examination. Inspection. Generalized Generalized reduction in muscle bulk is noted, more prominent in proximal muscles of both upper and lower limbs. No muscles hypertrophy and deformity and mild fasciculations are seen. Tone is decreased in all four limbs. In tone case, we elicited all the four limbs: extension, abduction, adduction, and flexion also. All are decreased, not much decreased. Decreased in upper limbs are more decreased. Lower limbs generally absent, but I observed some what normal hypo. And power. Right upper, all the four limbs: right upper limb, left upper limb, right lower limb, left lower limb, 3 by 5. Why are 3 by 5? It is movements are okay, but with gravity it is not much absorbed. Deep tendon reflex. Deep tendon reflex are absent in both upper and lower limbs. These are the findings: bicep reflex, tricep reflex, supinator reflex, knee reflex, ankle reflex, jaw jerk. All are in this case all are absent. Jaw jerk is okay, normal. Deep tendon reflex. Superficial reflex. Superficial reflex are preserved. We observed lamellar tap reflex, abdominal reflex, placental reflex. All are present. Sensory system. All sensory systems are usually normal. Patient perceive all sensory sensation. Autonomic nervous system. Pupillary functions. Pupils are not equal, bilateral, reactive to light, accommodation, direct consensual light reflex are intact. Heart rate. Heart rate is within the normal range for age. Pulse is regular with normal rhythm and volume. Blood pressure. Blood pressure is within normal range for age. No evidence of postural hypotension. Sweating is normal, appropriate for environmental conditions. No excessive sweatings and anhydrous is noted. Autonomic nervous system is normal. Pupillary response, heart rate, blood pressure, sweating, temperature regulation are intact with no evidence of autonomic dysfunction. Respiratory findings. Inspection. Chest shape is normal with thoracolumbar kyphoscoliosis present. Chest symmetry. Bilateral symmetry. Chest movements are normal and bilaterally equal. Which present. No sinus, no scars, sinuses, swelling or dilated veins. Apex peak is visible. No visible abnormal pulsation. Paradoxical breathing present. Chest wall retraction are present. Palpations. Trachea centrally placed. Chest movements reduced bilaterally. Tenderness absent. Walker parameters equal on both sides. Transverse diameter is to anterior posterior diameter are measured. In transverse diameter, I got to know that it weighs about 18 centimeters and anterior posterior diameter is weighed about 9 centimeters, which is 2:1 ratio. Percussion. Resonant note over both lungs. Cardiac dullness appreciated over precardial. No hyperresonance. Auscultation. Breath sounds, vascular breath sound present bilaterally. Vocal resonance normal. Added sounds, coarse crepitation, breath sounds are present. Other systemic examination. Serious. S1 and S2 heard normally with no added sounds are normal. Heart rate was regular. Cardiovascular examination was within normal. GIT, gastrointestinal system. Abdomen was soft and non-tender. No organomegaly are present. Bowel sounds are normal heard. Diagnosis. We came to know that 5-year-old child with genetically confirmed spinal muscular atrophy type 2 currently admitted with acute lower respiratory tract infection, which is diagnosed as bronchiolitis. Basis of diagnosis: multiple ligation dependent probe amplification genetic test. This is a test name. Homozygous deletion of SMN1, exon 7 and exon 8. Diagnostic of 5q SMA. 5q is a chromosome. SMN2 duplication present. Differential diagnosis: Duchenne muscular dystrophy, congenital myopathy, congenital muscular dystrophy, Poppy diseases. Duchenne muscular dystrophy, progressive proximal weakness after 2 to 5 years, cough, pseudohypertrophy, Grover signs, reflexes list, no tongue fasciculation. These what I am mentioning is the findings. Congenital myopathy, weakness from birth, facial weakness. congenital muscular dystrophy, severe hypotonia from birth, joint contractures. Pompe disease, hypotonia with cardiomegaly, hypotonic cardiomyopathy, macroglossia. These are the clinical features. What I mentioned. Investigation, hematology. Total WBC count in this case is elevated. Neutrophils increase, lymphocyte decrease, eosinophils increases, PCV 41%. Investigations. Respiratory system, bilaterally closed crepitation present, suggestive of lower respiratory tract infection, bronchopneumonia. Neurological, known case of SMA, spinal muscular atrophy, neuromuscular weakness, predisposition to poor cough and respiratory infections. Investigation. TLC, chest pain, chest X-rays, AP view, cardio outline appear normal in shape, mild bilateral perihelial interstitial bronchiovascular prominence is seen with no pleural effusions or pneumothorax. Mild thoracolumbar scoliosis observed. This view of chest X-ray. Spine X-ray, AP view. Thoracolumbar scoliosis with left side curvature is present. Vertebral bodies appear maintained without obvious bony destruction. Pelvic alignment is preserved. Whole spine chest X-ray. Thoracolumbar levoscoliosis is evident. Lung field show no focal consolidations. Heart size is normal. Findings are consistent with neuromuscular scoliosis, which can be seen in spinal muscular atrophy type 2. Treatment. Treatment administered. Injection band of 1 mg per kg body weight dose. Injection amoxicillin 275 mg. Injection paracetamol, nebulization with mucomist, plus 3% normal saline, ambroxol syrup, UV syrup, PLM syrup 250 mg 5 ml. Advice. Finally, advice. Continue regular physiotherapy and daily range of motion exercise. Perform chest physiotherapy and breathing exercise. Maintain adequate nutrition, hydration, monitor swallowing. Keep immunization up to date. Consider influenza and pneumococcal vaccines are advised. Prevent respiratory infection by maintaining hand hygiene, avoiding sick contacts. Regular follow-up with pediatric neurology, pulmonology, physiotherapy and orthopedics. Monitor for scoliosis, contractures and respiratory complications. Seek immediate medical care for fever, breathing difficulty, persistent cough or poor feeding. Provide psychological support and encourage school and social participations. Offer genetic counseling for the family. Thank you.